Hi all, just wanted to talk a little bit about last week in the classroom. I'd go over a few quiz questions and then go ahead and talk a little bit about this week, week 4, week 5. So I'm going to hop over to the classroom quick. So week 4 was our discussion of Medicare and Medicaid. Hopefully, if you didn't already have a good understanding of those two very important programs, you have one now. Well, actually, all of you work in healthcare currently. And so you're probably aware of the fact that in any hospital, and actually in a good number of physician practices as well, the percent of patients that you have in your facility that have Medicare or Medicaid or both dual eligibles make up the vast majority of patients that you have. So it's very important that we're understanding of the system overall, and also understanding of the fact that it is constantly in flux right now. So many changes coming, constantly updating different, moving to different payment systems and under value-based purchasing, new rules with regard to quality management programs. All of these different things make it a difficult topic to stay on top of. Hence the reason that you likely have a compliance officer in your facility that helps to keep everyone in check and helps them to understand, what's currently going on in that particular, with regard to that particular environment. So I will hop over to PowerPoint here for the quiz questions. Okay, sorry about that. I seem to be having some technical difficulties today. So hopefully I can get through the rest of this without issue. The first two questions on this slide, I actually tossed both of these. As you probably have noticed, not everyone gets all the, or at least in our Edpuzzle discussions, not everyone gets all the same questions. So you may or may not have gotten this question, but in either case, I did go back in and give you credit. First question is, which of the following is not an eligibility requirement for Medicaid? The answers that were given were age, gender, and income, I think, and none of the above were the four optional options for your answer. And so that it just didn't work for this question. There should not have been a not here. It should have said which of the following is an eligibility requirement for Medicaid, which is income. Medicaid is the low-income government-based payer. So income is certainly an eligibility requirement. Next question, which law extended expiring program authorizations and appropriations, including the SGR for physician reimbursement under Medicare? Now, the first time I recorded this, I went through this long diatribe about how the SGR had been repealed, and the SGR was repealed, but that was repealed under MACRA, which is what it thought the correct answer was. The law that extended the authorizations, including the SGR, was the Protecting Access to Medicare Act. Yeah, Protecting Access to PAMA. PAMA is what it's commonly known as, but it's Protecting Access to Medicare Act. That happened in 2014. MACRA happened in 2015, and MACRA got away from this SGR for physician reimbursement. And the SGR, Sustainable Growth Rate, it was a program put in place by Medicare to cut physician payments year over year. And the cuts were huge. They were 20, 30, 40%. And every year that when this would come up, the American Medical Association would lobby the Congress and the Senate to do away with that SGR. It usually ended up being part of the budget bill. So every year the budget bill would come through, and there would be an adder at the bottom of how the legislative branch of the government overrode this requirement that this government agency put in place. So in 2014, the PAMA, Protecting Access to Medicare Act, that actually extended the SGR, but only until the next year in 2015 when MACRA came through and did away with the SGR for good generally, but it also had a much larger impact on the billing, coding, and reimbursement world. It delayed the implementation of ICD-10. So that's what MACRA is mostly known for, but it was also for the physicians of the world. They're probably happy that's gone because that was a potential huge cut in their paycheck. You could have gone on, on the day before the end of the fiscal year, and Medicare would have paid $100 for your visit to the doctor. The day after the start of the fiscal year, they're only going to pay $70. So it was, I can see the need to cut payments, but it was so vast, so significant that it was just never going to fly. Okay, next question. This one is not a toss one. This is one to discuss. So the Stark Law prohibits, and there's lots of answers here. I won't read them all, but the correct answer was physicians from referring patients to an organization in which it has a vested financial interest. And the Stark Law is very complex. There's Stark 1 and Stark 2. It's an incredibly complex law, but the general gist of it is you can't refer patients. Let's say I'm a physician, but I own a radiology center as well, like an independent radiology site. I, as a physician, can't refer patients to that facility just generally because I have a financial interest in them going to that facility. Now, if the patient chooses to go there and isn't directed by you to go there, then it's not a Stark violation. And there are many different elements of, I can't think of the word that they use. It's not safe harbors because that's just for the anti-kickback law, anti-kickback rule. But it's very similar to the federal safe harbors under the anti-kickback rule, where there are certain options that are okay within Stark to allow physicians to have patients go to facilities that they own. For example, a lot of orthopedic, especially in big cities, a lot of orthopedic physicians, it's an oddity here in Pittsburgh because we don't have any private practicing physicians for the most part, but in other places where there are some, a large orthopedic practice may actually build an ambulatory surgery center where they can do their work. Now, these docs will typically also have privileges at hospitals and at other AM-Surg centers, and so you would think, oh, well, that would be a Stark violation to send patients to their own facility. It's more like if the patients choose to go to that facility, it's okay. And ultimately, they will have, they will gain some financially by having a patient go to the facility that they own. But it's about pushing all of your patients there. So if you opened a physician-owned ambulatory surgery center and sent all of your patients there, that would be a Stark violation. So that's where the key comes in there. Federal safe harbors. So I knew we were going to talk about safe harbors. Safe harbors are the answer in the quiz question, physician payment practices that are safe from federal prosecution. So this has to do with the anti-kickback rule, anti-kickback laws. And so oftentimes physicians will work for vendors, they'll work for hospitals as maybe a chief medical officer or something like that, but then they still also have their own practice that they operate. And so anti-kickback says you can't, the hospital can't provide a kickback, or a bribe is really what it is. A hospital can't provide that kickback back to that physician because of those that work he's doing, like maybe as a medical chief medical officer, or maybe related to being medical director of a certain service, like emergency medical services, or medical director over OB, something like that. So the hospital cannot pay those folks, those physicians, based on the fact that they refer patients to that hospital. That would be a violation of the anti-kickback rule. What is safe are what are listed out in the federal safe harbors, where perhaps let's say a physician agrees to come on and be the medical director of a department. It doesn't mean he's there every day. It doesn't mean it's his full-time job, but he has to put in X number of hours, and that would be all laid out contractually. Put in X number of hours. Nothing is related to the referrals that he sends to that facility, et cetera, et cetera. It needs to be very detailed. And that's in one of the safe harbors. If it's for a contracted service that is that physician payment practice is safe,
if it's a contracted service with demonstrated time, time logs completed, all of those types of things. So it's the anti-kickback rule is not quite as complex as Stark, but almost, and something important to be aware of. And that's why anytime that you are contracting, you're a facility and you're contracting with providers for services outside of just providing clinical care, we need to be very, very careful that we're not violating Stark or any kickback, depending on what the relationship is there. Okay, so let's hop into the classroom. Week 5, we're going to talk about setting charges. So remember, and I think I've mentioned this before, charges are the amount of money that the hospital charges for their service. It is not the amount that they are reimbursed. So charges are the same for every patient that walks in the door. Every patient gets charged the same amount. What happens typically is your computer systems, your patient financial services systems are very intelligent, and they will immediately, like if it's a Medicare patient, you put in the charge of $300 and it will automatically do a contractual write-off. So it'll take off that difference between what Medicare is going to pay, what the system knows the patient's going to be responsible for because it's that smart, and then what's left it'll write off. So charges need to be set in a reasonable manner, and here's why. Because if you're a self-pay patient, you're going to pay charges. You don't necessarily have the ability to have those contractual write-offs. Now, what is always recommended is if you're a self-pay patient that you negotiate with your organization that you're seeing providers at to either get a discount for paying in a timely manner or to even take part in their financial assistance program. Because oftentimes people that are self-pay because they can't afford their insurance, so they just go without. And so those people are not necessarily going to be able to pay their $18,000 hospital bill, but they may be able to work with the financial assistance program at the hospital to get a grant to pay off 3/4 of it and then make payments on the rest for the next 2 years. The hospitals are typically very good about that, to work with people because they'd rather get what's ultimately going to happen is they'll work to collect for about 90 days, whatever the state law is. In New York, that's 90 days. But you only have to make a reasonable attempt to collect over whatever state law says. And then they sell those accounts to a collection agency a lot of the time and get pennies on the dollar for them. So it makes much more sense for facilities to work with patients up front, deal with their financial issues, hopefully get them enrolled in Medicaid or some other program. A lot of times there are Medicaid programs across the country, specialized ones in states that are for catastrophic injury, for people that have certain conditions like cancer or dealing with family planning issues, pregnancy, all of those things. So sometimes the folks at the hospital will know how to navigate the system and get folks coverage that might need it. But so what we're talking about this week is some of that. We're going to look at some of the reimbursement or some of the charge setting piece. We're also going to talk a little bit about value-based healthcare and the transition moving from where we are now or where we have been, where it's a fee-for-service model to this new value-based care model. And is that model, and that goes to our discussion for this week, is that model smart? Will it help to restore public confidence, etc.? So lots of interesting stuff for this week, and I think that's it. You also have a PowerPoint assignment to a small. It's a small case study. It's not really a case study. It's only 3 sentences long, but kind of a case study to examine an issue in a facility. So that should be a PowerPoint, and then obviously we have our discussion and our quiz for this week. So that's all I've got. If you have any questions, please reach out. I think you guys are all fully online students, but so make sure that you have, if you're continuing on in the fall, if you're not done yet, and will be taking fall classes or summer classes for that matter, make sure that you get your information into the RMU Online folks, whichever program you're in. I know Erin, Shar for you, Shar Sungard. For the nursing folks, I'm not exactly sure who does that. Actually, Renee may help you with that right in our office. But make sure you get everything into them. Main registration for on-ground students started today. So they will start to claim spots in various online classes that you might need overall. So be sure that you get registered into your classes. That's all I've got. So see everyone in the boards. Thanks.